Okay, perfect. Thank you very much. I'm going to talk about the annotation of the critical view of safety, and specifically the annotation requirements for such a large-scale worldwide collaborative project, such as the CVS challenge. As we all know, machine learning means to enable machines to acquire knowledge from data and to perform certain tasks, such as classification tasks, without being explicitly programmed to do so. In the case of supervised machine learning, we have an annotated data set labeled with respect to clinically relevant target features, and we split that data set into two parts.
Jennifer, I think you are sharing the presenter view.
Oh, sorry, thank you, perfect. Let's see. This should be it. Better now, Yutan?
No, it's still presenter.
Let's see how we can fix this. Now it should be better.
Yes. Perfect.
Perfect. Okay. So machine learning, enabling machines to acquire knowledge and perform classification tasks. Supervised machine learning means we split an annotated or labeled data set into two parts. And we train the algorithm on the labeled part to recognize these visual labels. And we test the algorithm's performance on the unlabeled part. And then we evaluate the algorithm's performance correlating with those labels. Therefore, annotations serve as the ground truth, and the algorithms are only as good as what we teach them to recognize. The critical view of safety is a universally recognized safety measure for laparoscopic cholecystectomy established by Dr. Strasberg and colleagues, consistent of two and only two structures leading into the gallbladder, the hepatocystic triangle being cleared of fat and fibrous tissue, and the gallbladder being lifted off the liver bed to expose the cystic plate. As we all know, this has worldwide been established to prevent accidental injury of the common bile duct, and is a widely recognized notion, and probably the first and only safety notion that has actually clinically proven to prevent intraoperative complications. How to annotate such a complex phenomena, the three pillars of the critical view of safety. Being a good surgeon and achieving the CVS in all of your operations, all of your lab colleagues, does not necessarily mean obtaining and composing a good data set, because clinical perception, what we see as surgeons in the video, the visual characteristics we pick up on and we base our intraoperative decision-making on, may not be the same visual characteristics that a machine or an algorithm perceives and picks up on. Therefore, annotations have to be consistent, they have to be objective, they have to be universally reproducible and apply anywhere and be understood anywhere in the world. They have to reflect clinical value as well as be machine readable. And as I said, defining the ground truth for such a meaningful clinical safety measure, such as the critical view of safety, was not as straightforward as it appears. We first composed an annotation protocol. We therefore deployed the expertise of our clinical and technical advisory committees that we composed and underwent 2 Delphi rounds to compose an annotation protocol. We exposed them to images such as this one and asked them to define and refine definitions of specific to annotations of the 3 CVS criteria. As you can see, we received quite heterogeneous results, especially with ambiguous images, still frames such as this one. And we had quite a bit of discordance between the experts that we consulted. Therefore, we refined the protocol to reflect that heterogeneous view of the critical view of safety and how it should be annotated. We added examples, we added pros and cons, we added achieved and not achieved criteria to make it more specific and broaden the annotation curriculum. We then had the experts annotate 60 videos in Mosaic to validate the practical implication of the composed protocol. We had them annotate the 60 videos from Massachusetts General Hospital and IHU Strasbourg, and they completed the overall video annotation as well as individual frame annotation, as Jean-Paul described earlier. We discovered that there was a lot of annotation based on clinical experience rather than on the strict definitions of the protocol. We discovered that many of the individual frame annotations were based on the video context. So if the critical view of safety was seen in the video, the individual frames were also annotated as all three of the criteria achieved. And we saw that optical problems such as a smoky lens or a very bloody visual optic of the case, or the instruments obstructing the view onto the three criteria impacted the quality of the annotations of the experts. And the overall annotation difficulty, we saw that the protocol did not yet reflect and did not yet sufficiently describe how to annotate the CVS to achieve a consistent and clear and homogeneous annotation among these experts. Therefore, how do we address these inconsistencies in annotations? We conducted qualitative interviews with individually with all of the experts, and I want to take the time to say thank you for all of your commitment to this and for your time and your engagement in the challenge in your busy lives and surgical practice, because this really led to the composition of a thorough and reliable protocol. And then we re-annotated the entire data set based on the results of these qualitative interviews and based on the refinement of the protocol. The qualitative interviews featured problematic frames, still frames. We showed them frames of all of the entire data set, but mainly the ones that really obtained or achieved very heterogeneous labels by the experts. This resulted in an extension of the protocol to give more examples, to convey sort of when to consult the video context. So when not to look only at the frame, only annotate what you see, but also consult the few seconds before and the few seconds after that still frame. We revised the criteria to be more strict. For example, we revised that the cystic plate should be exposed to the lower third of the cystic plate should be exposed. And we provided many more examples to reinforce the protocol. Now, we are faced with the question of how to convey this protocol and all of this insight that we gained throughout the process of composing this to a worldwide panel of annotators with very different backgrounds and very different expertise, surgical expertise, as well as annotation expertise. So we opted for a multimodal explanation. On one hand, you can find the critical view safety annotation protocol as a PDF. You can read through it, you can print it out, you can look at the individual images, but we thought that was not enough. Therefore, we wanted to really give another mean of conveying the annotation protocol and the annotation school. Therefore, we're going to launch a CVS annotation school video at SAGES 2023, a little sneak peek at the video, giving lots of examples, explaining how we obtained these annotations, how you got to these annotations. This is only a short teaser. The video will be around 8 minutes long and will be available upon signing up to Mosaic as an annotator. And then additionally to that, we give the opportunity to complete a trial annotation of a couple of videos in Mosaic to play around with the software, but also to see really what the requirements are and face annotation difficulties. We provide feedback throughout the whole process. Then with the annotation school, annotators will be asked to complete annotations of 60 videos, and we're going to compare their performance to the expert and ground truth annotations that we established before we let them loose to annotate the entire data set. So please get involved, sign up to become an annotator, sign up to Mosaic. The link is on our website. And yeah, annotate away. Feel free to reach out regarding any questions through the question and answer box, but also email info@cvschallenge.org.